Hi, and welcome to everybody who's joined us this afternoon. So this is the second part of the Forward ME AGM. And Ellie, I think you've not got, that's it. Thank you. And we're really, really delighted that you've joined us this afternoon. And we are completely thrilled to have Tahlia Ruschioni from the Bateman Horne Center to join us this afternoon. Tahlia brings with her more than 20 years experience. This ranges from bedside care all the way through to medical education, advocacy, and Tahlia is currently the executive director at the Bateman Horne Center. She's led global expansions of its medical education and its clinical infrastructure, and is absolutely dedicated to elevating the standards of care for people living with ME and long COVID and other related conditions. So, as Tahlia has said, and we'd certainly echo this in the UK, the need for well-informed medical professions has never been more urgent. So we've asked Tahlia to share with us today the story of the clinical care guide that's been produced, and also about its implementation, and perhaps move on to some of the examples of best practice that we would hope to learn from in the UK. But I know that our audience goes wider than the UK, because we've had questions and comments in from other places around the world. So delighted to have so many people on board with us. And thank you so much for getting up so early, Tahlia. Whereabouts are you? Are you calling in from?
So I'm actually in Colorado, where my sister is. Yep.
Okay,
So it's not
lovely.
too bad. 8 a.m. It's not too bad.
Great. Okay, so over to you. We're going to Talia's going to talk for 30 to 40 minutes. We encourage everybody to put any questions they would like put to Tahlia in the chat, and I'll pick those up at the end, and we'll do a quick Q&A session. This session is being recorded, but it's being recorded with a spotlight on Tahlia as a speaker. So nobody's names will appear in any recording. So just wanted to reassure people. Okay, Tahlia, handing over to you then. Thank you. Thank you so much for
Okay.
coming.
Well, first of all, thank you so much for having me and inviting the Bateman Horne Center. This is one of probably my favorite productions that we've had at Bateman Horne Center, but also one of the most meaningful. So, a little bit about me. I am the executive director of Bateman Horne Center, and I remain the education director as well. I joined Bateman Horne Center in, I think, June of 2019. So I've really been able to see the field itself change through the pandemic, looking at how Bateman Horne Center has evolved over those years, and really trying to help focus in on what our Center of Excellence can do to help close that knowledge gap. On a personal note, my sister has pretty severe ME/CFS, and I came to Bateman Horne Center because I met Dr. Lucinda Bateman while I was doing
Mhm.
medical education for the Mountain West states in the United States, working at the University of Utah. And when I heard Dr. Bateman talking about ME/CFS, it clicked for me that both my sister and my dad have ME, but my sister is quite severe. And so watching her go through this, even with really good providers and expertise, just tells me that we have the obligation to make sure that more people have the opportunity and access that we've been blessed with. So that's kind of where my why comes from. And also, I now admittedly live with long COVID ME myself. So I have learned from both a professional lens, but also a personal lens from multiple, being a caregiver, but also someone with lived experience now. I think it's helped me translate our education in a more meaningful way. So that's a little bit about me. Just quickly, uh, just for purposes to disclose, if we talk about any treatments or tools during this presentation, they're for educational purposes only and should not be interpreted as commercial endorsement nor medical advice from Bateman Horne Center. If you are unfamiliar with BHC, we are a 501c3 nonprofit organization based out of Salt Lake City, Utah. Our focus has been from the beginning to improve the lives of people living with ME/CFS, fibromyalgia, and post-infectious conditions like long COVID or PASC. We do that through the lens of our direct clinical care that we provide. We conduct both diagnostic and clinical research, and of course, my passion piece is the education for patients, caregivers, and medical professionals. We also focus heavily on the comorbid conditions that come with these illnesses because there's so much that can be done to help support patients improve their outcomes and stability. And I think that that's kind of where my calling comes in with all professionals can do this. It's not just a niche anymore, especially after the pandemic. So the topic today is about the development of our clinical care guide. That's the QR code. I've also put the URL link into the chat. This was developed with the support of the Open Medicine Foundation under our joint umbrella of our Medical Education Resource Center at BHC, known as MERC. I could not have done this without my amazing colleagues. They deserve a few moments of acknowledgement. This clinical care guide was a deeply collaborative effort involving this interdisciplinary group of clinicians, educators, researchers, patients, and lived experience professionals who I have not named because they've wished to remain private, but they absolutely played a significant role in this development. Their willingness to share that education, to debate our approaches and refine our ideas together is really what shaped what you're seeing today. I also do want to take a moment to recognize the many lived experience professionals who have supported BHC through my time and what predates that. These individuals living with these conditions have been instrumental, and they have helped me understand the realities of this illness, but also help the medical field understand how we can better support the care and the care and support of these patients. So this may seem obvious, but the clinical care guide was desperately needed. I think that what we experience in the United States is not isolated to the United States. We all have a limited number of trained ME/CFS professionals out there, and those that are out there are often very siloed because they too experience their own stigma in this world of medicine. There's a lot of fragmented clinical care that we all experience as patients, but so do these professionals. There's a lot of diagnostic uncertainty because there are different guidelines based wherever you are in the world, and I think that adds to a lot of this confusion. I've seen more of a synthesis come together, especially during, and I don't think we can really say after the pandemic because it's still here, but there has been a big evolution and push to find more of that clinical consensus. So what we are hoping that this clinical care guide can do is help to fill that knowledge gap a bit. The other big thing in the United States is that insurance and time-based billing does not allow providers to practice medicine in the way that they need to. And I would argue that's probably throughout the world, but just in, a different shape or form. So here it's productivity. And when you have a complex multi-system illness, it can be really hard to provide adequate care or feel like you have enough tools to do that in a 15-minute visit. So that's where this guide was trying to come into play, giving them those tools. So, again, this isn't news to any of us, but when you consider that roughly 4.5% of individuals following COVID-19 now meet the criteria for ME/CFS, you're talking about a significant number of people who are flooding our healthcare systems globally. Many of the providers have found themselves caring for patients with these complex post-infectious illnesses without any formal training or practical clinical frameworks. So once again, that's why we have focused heavily on providing some of that education and resource. The origins of the clinical care guide. So I stepped back trying to think as a patient, what could I bring to my primary care? What could I bring to one of my specialists that would give them an actual tangible roadmap or guide that they could quickly reference, even if it was a 15-minute visit? So I pulled together all of our lectures. We've got numerous grand rounds for different disciplines. We hold an internal clinical rounds or clinician hour that's kind of private to BHC, but we have a multidisciplinary group that joins us from around the US, Canada. I think there's one or two doctors from the UK, Greece, and Australia, and we'll talk about clinical cases. They'll bring forth some of their treatment guidelines and approach to care. Our Project Echo program, so the long COVID and post-infectious syndrome echo that we've been running with the University of Utah since 2022 was a gold mine for me. We literally structured our echo series from 2022 to present, where we broke down the diagnostic criteria of ME, long COVID, and then we focused in on the comorbid conditions, and we provided diagnostic and assessment frameworks and clinical management strategies. So I ended up pulling the this body of literature, if you will, or curriculum together that has developed from Bateman Horne Center, and it started to build this framework for me. I was pulling the transcript, so it wasn't me, right, doing this, but it was from the providers themselves. And then Dr. Melanie Hoppers and I, one of our clinicians here, we sat down and just started to frame this out. What are we seeing as a recurring diagnostic and management theme in our clinic, but also among our partners that are out there working with us? And then we started to structure those chapters accordingly. So my hope wasn't to duplicate the efforts of the U.S. Clinician Coalition's guidelines, but rather expand and offer a little bit more meat to what they had already started. And as I've said a few times, this was a truly interdisciplinary development team. So we pulled in internal med, peds, family medicine, women's health, rheumatology, cardiology, and you can read the other bullet points here. But the intention behind that is that this illness is multi-system. And if we do it just one way or quote our way, then we're not seeing the whole picture of the providers that touch these patients' lives, right? And we've learned that partnering with a lot of our allied professionals, physical therapy, occupational speech, neuropsychology, mental and behavioral health, we can see how these patients are living inside their bodies every day. And if we don't create a resource guide that includes that, then we're failing the patients, right? So we all started to co-write and co-develop those chapters. And then we actually had people from the other disciplines reading that provider's chapter, right? So that we made sure that it was relatable and could translate across disciplines. This was one of the hardest pieces, was that review and reaching consensus. And yet I step back now and think this was probably one of my favorite. In the end, this was one of my favorite moments. I wouldn't say that during that process, but now I can say that because what I was able to see when we had this team come together and do that cross-disciplinary review is that it extended this dialogue about how we're approaching the care of these patients in a way that helped us synthesize that this is the standard. We may be coming at this from different angles or different scopes, but in the end, our approach remains the same. And that therein lies the standard of care that we feel all patients with infection-associated chronic conditions should be met with. So that's really where this evolved from. That development time, I might be undershooting this, but it was at least 8 months of work. We're pulling all of this together, the transcripts, the content, framing it out, writing these chapters, the contributions and revisions, I think, is what took the longest and was probably the most meaningful piece of why this is such a whole person approach to care. And the editing took some time as well. So about 8 months, probably a year, if I'm being honest. We released our first edition of this in May 2025. As we are approaching that, we are looking at what additional edits should we be making. We've received a lot of community feedback on how we can strengthen this, how we can add a little bit more clarity and other considerations such as like vaccine injury, the importance of infection prevention from the start, and adding chapters like that into this. So we always welcome community feedback so that we collectively can create something that serves all purposes. We also released this January of 2026 on Amazon for purchase, just because we were finding that a lot of patients were asking us to send this to their providers. And honestly, the cost of us doing it in-house was just about as much as it was for purchase and shipping on Amazon, and then it can go directly and internationally. So that's why we made that move. So the structure of the guide itself, we really wanted to be able to provide these healthcare professionals with not just the diagnostic criteria, but how to make a differential diagnosis. That is incredibly meaningful in the world of medicine, and that's how these providers can then start targeting the areas that so many ME and long COVID patients experience. And then, of course, going into those comorbidities, because as I said before, I really think that that's where all providers can make a difference, even if they don't completely understand the pathophysiology of ME/CFS, right? So we have chapters on dysautonomia and autonomic dysfunction. Disordered and dysregulated sleep is a major contribution to PEM and a lot of the downstream impacts of ME, mast cell activation, hypermobility spectrum disorders and connective tissue disorders, cognitive impairment, post-exertional malaise, of course. That was a significant chapter, and we highlight the importance of that constantly. GI dysmotility is another big thing that we see in the ME world, and so we included that. Pain, fibromyalgia, small fiber neuropathy, and then we took the chance on writing a chapter with the biomechanical and vascular considerations. I say it that way because this is still so nuanced and so new, I would argue, to our field of medicine, and yet we're seeing more and more correlation. So it just felt like our responsibilities to start talking about this and also talk about the harms that can be done by providers that do not know what they're doing. And so that's why we took the chance in writing this chapter, so that we could help prevent some of that harm, but also direct in the most appropriate ways. We have a couple of additional chapters here that I just felt like we couldn't not include if we're talking about ME/CFS, which are the pediatric and young adult populations. Dr. Melanie Hoppers, who helped me do a significant lift in the framing and writing of this care guide, she is from the pediatric world, and so her input with Dr. Peter Rowe and Dr. Azola and whatnot really helped shape that chapter. Of course, there's never enough literature on the severe and very severe. And once again, we felt like if we had this platform, we have to call attention to this very unseen population. Caregiving is another big role in how providers can support the caregivers in their role. And so that then supports the patient in a better way. And then disability and accommodations is a really important topic for at least here in the United States. So, and in our appendices, we have medication and prescribing sheets. So based on whatever chapter, the meds, the dose, and a note on that, I have seen more and more providers come back and say, that's my favorite piece of this whole guide, because I can quickly just pull it up and go to exactly what I'm looking for. One of the neuropsychologists, Dr. Michelle Haddad, put together an assistive cognitive strategies handout, which helps with just we all experience that brain fog. And so there's some strategies to help get through the day and then some additional resources. The response to the guide has been amazing. It warms my heart because it was a significant lift, and what it has shown me is that the need was greater than we could have ever imagined. And so we've had thousands and thousands of digital downloads. One of our donors last year supported a campaign which allowed patients in the United States, because it was difficult trying to ship outside the United States, to give us one of their providers or a university and a provider at that university or academic center their contact information. So this was donor supported, but we were able to print off of Amazon 106, it's more than 164, but 164 copies that were shipped to providers around the United States at these centers. That in and of itself, on top of the data that we've been able to pull from the downloads, we're able to reach rural health providers, which I think is so important. A lot of the community clinics, academic and medical centers, as we all know, kind of run medicine. So being able to reach them there is really important. And then we've been able to ship and share this with many renowned universities. So the note I have on here is one of the most meaningful outcomes for me, at least, was seeing the geographic diversity of the clinicians who are seeking guidance. Another big focus that we've had, we are actively working to introduce the guide into medical schools, residency programs, and fellowship programs. If we can reach this generation sooner, we can help translate what they are now met with, which is this massive unmet need of patients sooner, right? And so a few of our members on our board of directors are clinicians, and so I asked them very nicely if they would tackle this project with me, which was sending our clinical care guide to the deans of education, course directors, residency directors at these med schools, and sharing the guide with different training programs and encouraging the incorporation of this into curriculum. Next on our list to tackle, we're writing and should be submitting soon a standards of care paper for the Federation of State Medical Boards here in the United States. This is outlining best practices in clinical management of IACCs. We're encouraging a broader clinician education, initiative and partnering on that together. And of course, we're referencing this clinical care guide as a tool and resource to them. Now I think it's a matter of scaling this, right? How can we disseminate and scale what has been created? So we're going to continue to use our Project Echo network of providers and others who have similar echoes to help just kind of keep expanding that hub and spoke model. We focus a lot at Bateman Horne Center on hands-on training. So we reserve several slots a year for bringing in residents and fellows and practicing clinicians. We've had clinicians from New Zealand and Israel and Canada, and I think I'm missing at least 2 other countries that have come to Bateman Horne Center because they have received grant funding to create a center like ours in their countries. And so not only just focusing on the United States, but making sure that this is expanding outside of just our walls. We focus heavily on continuing medical education credits here in the United States and those that can translate to other countries. We also focus heavily on grand rounds. So that's a really great way for us in the US to reach clinicians, but discipline-specific grand rounds. We have, as I mentioned previously, a private kind of clinician forum where we have a lot of case discussion. And I've learned through that network providers who can lean on each other do this with more confidence. And I think it's not a matter of competence. It is just that. It's a matter of giving them confidence to do this with us. And so not only are we strengthening the care that we provide, but they are too. So and then my next big hope is that we can take from that clinician forum and echo providers who can help write clinical consensus guidelines on, say, the stellate ganglion block and when you use that, or how you approach these vascular compression syndromes and whatnot. And then, of course, there's always power in writing case series. I'm hopeful that this clinical care guide can now offer some international adaptation. It was never meant to be a one-stop shop. The guide itself reflects the clinical practice guidelines that we are able to use in the United States. Of course, there's going to be prescribing differences. There's going to be insurance and healthcare constraints in various countries. And so this was largely targeting what we can do in the United States with the hope that it serves as a foundational framework for others to be able to adapt from. And then finally, really, we can't do this and we can't really change the way that medicine is practiced if we don't do it in a collaborative way. So the guide itself represents years of clinical observation at Bateman Horne Center, but also with our other partners in the field. It has to be interdisciplinary because this is a multi-system illness. We have to be working together to see the whole person and support them there. And lived experience professionals and patients, they have to be at the core of everything that we do because this is their experience that we're helping to translate into medicine and medical practice that providers can then understand and adapt. And then, of course, learning across those networks. So most importantly, the clinical care guide represents the power of collaboration. Clinicians from many disciplines came together. It brought their own perspective and experience, and it was united by the same shared goal of improving care for patients that have long been overlooked. So I think together, both specific to the United States, but internationally, we have to take a stand and look at how this practical guide can help expand and move the care forward globally. So that is my presentation.
Thank you so much, Tahlia. That was incredibly informative, very, very clear, and very, very much appreciated. There's loads of flying hands going up, so thank you very, very much. I think what's I don't know how many people here have managed to read the guide. It is just so clearly patient-centered, and it's so clearly built on lived experience that we recognise. But also, I'm not medically trained and it's extremely readable. So that's absolutely brilliant, but readable, I mean, by patients if at all possible, but readable by caregivers. And I think that's really, really important so that caregivers have some sense of how to, I think you used the phrase, Tahlia, about navigating uncertainty in the document and to help give caregivers and patients a bit of a route map of kind of where to go, what to ask for is absolutely invaluable. I'm just going to start off by we had one comment from Nigel, which is the term ME in much more common usage now in the US since we believe you invented chronic fatigue syndrome some time ago, but that would be interested to know. But also I mean, you ended up with a sense of how it's being kind of rolled out. So is a question from Odilon about the coordination, creation and distribution and promotion of it. Have you had any interest from the World Health Organization at this point in time? And have you had any engagement, particularly with low and medium income countries and the global south? You know, is it tending to be at the moment in the first world countries? So that would be interesting to start. I've then got a series of detailed questions and some other things to go through.
Sure. Great questions. So I think all of us can agree that the CFS portion of the ME is just such a disservice. So at BHC in particular, we have slowly started to adopt just calling it ME. And also long COVID ME, because I think that, of course, we have a subset that are truly long COVID, but then there is that more severe subset that does meet the criteria for ME/CFS, and so we try to tie long COVID ME, just calling it ME together as we're doing presentations, so that it starts to train, if you will, the learner to hear it and see it in that way, so that we're not siloing these, or we're not stigmatizing by just calling it CFS. I can't wait for them to just stop with that. So yes, we are adopting that more, at least through our networks. And then more specifically around the question of World Health Organization and more of the, was it third world? What was the second part of that?
Low,
I'm sorry.
medium, low and medium income countries. So yeah,
Yeah,
global south. Yeah,
we are trying very hard to reach. I think we're trying to reach everyone, and the way that I have found, at least, kind of a bang for your buck approach is through Project Echo, because Echo is global, right? It started with the intention of being able to provide that hub and spoke model to bring expert clinicians together and offer that expertise in rural health and underserved populations around the world. And so there are a lot of Project Echo programs that are international that we are reaching out to and trying to connect, where we can either offer to give a lecture, and then of course connect them to things like the clinical care guide, or other CMEs. But one of the best programs out there right now, I actually pulled it up because I had a feeling this might be asked, is the oh gosh, what's it called? It's SILC, and it's part of ECHO, but they are tied in with their World Health Organization collaborator. And so we have done a lot of lectures for them over the last 3 years, and they do reach a lot of English-speaking countries, but then a lot of Spanish, French, Portuguese, and Arabic countries as well. So it's one of those where you have to try to find, like, where's the source, so that you can try to, for lack of a better word, infiltrate. And I
yeah.
think that Project Echo is one of the best ways to do that.
So as an entry point, so just to say, Talia's put a link to the Echo initiatives into the chat, and further up the chat, thank you, Arthur, who's put a link to how we can find the clinical care guide on Amazon UK as well, because it's a different link to Amazon US. But
Thank you.
it appears to be there. So so
Good.
that's really good. And we obviously need to encourage all our clinicians to purchase that. And I don't know how much do you know how much it's going for, anybody? Anyway, you can put that in the chat. So
£18.
thank you. Okay. Is there an audio or a video version of any of this? Does it come in any
That
formats?
is next on our list.
Okay.
We do have a specific donor who is very focused on making sure that this clinical care guide does not have any barriers for access.
Yeah.
And so we are looking at creating an audio version of this, along with a couple of other just updates to the edition itself. Like I mentioned before, adding in a chapter around vaccine injury, a chapter around the importance of infection prevention from the beginning, right? And a couple of other things that we've received feedback on.
Okay, thank you. And I mean, in the UK, you'll be aware that we operate through NICE, National Institute of Clinical Excellence. And I mean, you made the point very powerfully, which is a point that we've been making very, very powerfully for a long time, about the need for a national centre for clinical excellence in the UK. Is there I mean, NICE has issued guidance for us in the UK, which thankfully the 2021 version is an absolutely ginormous improvement on the previous version. But is there anything much on ME/CFS and the CDC as your your national medical organization, isn't it? Center for Disease Control.
So y'all may know that the United States has gone through a bit of a political change,
Yes.
and that has heavily influenced our ability to, I would say, continue progressing the momentum that we had built during the height of the pandemic around both research and education funding for IACCs. And yet, I think that we're finding some unique opportunities to still try to push that agenda through different avenues. And the CDC has been hit pretty hard, right, with what the
Yeah.
changes. And so we do still have a significant body of professional research advocates that continue to push this forward to make sure that we don't lose a step. And while even predating what has recently happened, we started to see them adopting more and more of this in the United States and offering some decent education around it. And so I think we can collectively agree that we could all have our systems do better, but it is starting to move. And in the UK, we're trying to strengthen some of our partnerships there, including those who are connected to NICE. And so if you have opportunity or connections, feel free to send them my way because it's something that, again, if we start to create that network, that's how we start to make a movement, right?
Fantastic. Yes. I mean, I think there's some people on this call who could significantly assist with some of those UK links, and really, really welcome them being here. You talk about it being a first edition guide. Are there plans for, I mean, this should be the final question, but are there plans for a second edition that somehow could be co-produced across several countries? I mean, it has to some extent already been co-produced. You talked about input from various countries, New Zealand, Greece, Israel, and others. But would that be a potential way forward for a second edition?
I would welcome that. That would be amazing. Right now, our focus, well, I shouldn't say our focus, but right now the requests have been translation into different languages,
Mm.
and that's another area that we would welcome help with. But I think the hardest part is that the prescribing in different countries is going to be different, right? And also and so we've worked closely with a couple partners in Canada who are physicians who have taken sections of the prescription
Yeah.
sections of the clinical care guide and said this is a mechanism of action similar to X drug, right? So that would be something that we'd have to be careful with and
Mm.
just mindful of as we work together. But I would love to see us do a bigger partnership in that way.
I think we'd love to see it too, and obviously recognise that some of that prescribing would have to be tailored to each country's own formularies or restrictions or what have you. I've got a couple of detailed questions, and then we'll come back to the sort of broader questions again. Um, um, there was a question raised by somebody who's present, but about vitamins and about recommendations of vitamins. Is that something you could comment on briefly?
So I don't think we went too deep into that with the clinical care guide, but we do have through our Project Echo series, well, she's the long COVID director at the University of Utah. She did a whole lecture on vitamins and supplements and also the cautions of using them and the
Mm.
interactions with other medications. I'm going to put in the chat our YouTube channel with the caveat that it needs help. So it's something that we're working on. There's a lot of information on here, and one of our initiatives this year is really trying to clean up our website, but also our YouTube channel, so information's just easier to get to. So in on our YouTube channel, if you go to our Echo list, I'll just find it as we're talking. She talks a little bit more about the vitamins and supplements with caution and how to use them.
Okay, thank you. And a question, well, we've had a couple of questions in which talk about strategies for recovery, understanding pacing, understanding the use of exercise. I mean, I think they're well covered in your guide, but I don't know whether you'd like to highlight a few key messages.
I mean, we don't prescribe graded exercise, right? And yet, I will say that we listen to the patient's body. I think that regardless of wherever someone is at with their ME journey, you have to listen to their body and what their body is able to do and not do. And so in our minds, the most important thing is, can you brush your teeth? Can you take a shower? Can you get to the bathroom, right? Like that is exercise. Let's be real in an ME body. Just eating is exercise. Everything is an energy exchange. And so I think we have to redefine what exercise means, especially
Mhm.
when you're living with a multi-system illness like this. So um, we don't go there unless the patient is able to start progressing their ADLs in a way, their activities of daily living, such that we can start to introduce a little bit more what I would call movement, not exercise, and whatever that might look like. Getting to the car, getting to the mailbox, that again is all an energy exchange.
Okay. Thank you. I think some of the more detailed questions about that need to you need to have a chance to read the guide, and then I'm sure people can be in touch with Bateman Horne Center directly if they find that useful. That we had a question sent in as well, which is about providing support to a loved one to navigate the whole system, really about how you make decisions about accessing medical care, investigations, dental care, vaccinations, when you know that doing any of those things in themselves are likely to create crashes and lapses. So is that covered in your guide?
In the caregiver chapter, we do talk about the importance of the caregiver and provider relationship as it relates to supporting the patient. Um, and also, as a caregiver, the reality is it's hard, right? It's not just
Yes.
mentally and emotionally hard to watch my sister continue to, lose herself to this illness. But there's a lot that comes with it financially. There's a lot that comes with supporting the everyday needs and trying to adapt to the fluctuations of this illness, and trying to be able to convey that to providers is so hard. So we took the opportunity in the clinical care guide to address some of that for caregivers and the importance of making sure that caregivers have a support network around them too, right? So.
Absolutely. And that can be one of the hardest things because it's such an isolating illness. So, yeah, we continue with the message of strongly encouraging people to find others in your local area to meet up with, even if that seems like the last thing you feel like doing. It is potentially beneficial in the longer term. Question about seeing ME as it being termed as post-infection or post-viral illness. Does that run any risk of missing out people who are not aware that they've contracted ME from an infection or a viral infection, or who may have contracted ME through another route?
Great question, and thank you for allowing me the opportunity to clarify. So we often will call it that, but yet we identify that TBIs, pregnancy, there's many different things that can lead to ME/CFS, right? There are structural damages and vascular compression syndromes and whatnot, right? And all of that can, one could argue, have some neuroimmune response, but we don't want to blanket this in a way that does not capture everyone. And so when we do our lectures, and I believe even in the clinical care guide, we call out other things that we have seen that will translate into ME/CFS later in life or more acutely.
Okay. Thank you. Uh, in the UK, we're certainly feeling like we take, one step forward and then we seem to be taking a few steps backwards as well. Have you had pushback against this guide? How have you handled that pushback? How does it kind of sit more generally?
I think that, yeah, you're going to have pushback regardless, right, of whatever you do in life, I would say. But especially when you put out something like this, because it can be interpreted in so many different ways. And although I wouldn't call it pushback, I think it's more some criticism from either us not being more clear from the beginning that this is specific to the United States, and so we're speaking to that kind of audience and structure that we live and work in, and yet everybody's feedback is helping to strengthen the product in a way where our second edition is more inclusive and comprehensive.
Mm.
So I wouldn't call it pushback necessarily, but have we received some strong feedback? Yes. And I hope that that just translates into a stronger product in our second edition.
Okay, thank you, thank you. One of the major concerns in the UK at the moment is, well, one of many is we have some very severely ill young women by and large in hospitals around the country who are receiving inappropriate care, and we're extremely worried about them. They're at a life-threatening stage. We've also lost a number of young women over the last few years. Is that the same in the US? Do you manage to intervene in very severe cases?
Um, that's a tough one to answer because it is sensitive, right? We cannot legally offer medical or clinical advice, but can we um, offer support and material? Can we offer, be an expert witness? Can we do those things? We have in the past, yes. It's not, again, it's a careful situation, but we try to um, offer what we can to the providers that are caring for that patient in a way that hopefully will better inform what they're doing to stop the harm.
Mm-hmm.
I think
Okay.
that's the most careful way I can answer that.
I notice Alison in the chat has just made mention of your group meetings. Do you want to give a plug for those?
The support groups.
Yeah.
Oh, yeah, man, I'm those support groups touch my heart every single month. We have a wonderful licensed clinical social worker, Timothy Wyman, who also has lived experience with chronic illness. And so he and previous lived experience professionals will run the forums themselves. And if it's within your time zone, let me find it, we would welcome more connection and support.
Okay, so they're intended for people across the globe. I think they are in our time zone. From memory, they're about 7 o'clock in the evening, but I might be wrong.
Um,
I think I've put the link in the chat.
oh, thank you. As I try to find
I
it.
think that's the right one, just to the support page.
Perfect.
And
Thank you.
and yeah, you'll notice in the chat a very positive message from somebody who's offering to be an advocate and volunteer with you.
Oh, great.
Oh, it's usually 8 p.m. Thank you, Alison. Yeah, we're interested as well in whether you can highlight any examples of best practice in the US. Are there particular states or are there particular places who you think these are actually providing quite a good model? Because we're just at the point of Ford ME and many of the other organisations and charities in the UK working with the DHSC on progressing what's been a published delivery plan, which we need to enhance and make it even more appropriate for patients living with ME. So we're constantly looking for best practice examples, and there really aren't many. in the UK at all.
Do you mean like specific centers and how they're structured,
Yeah.
or?
Yeah, or particularly rather than if you can't actually name them, but it's kind of what are the elements that you think are really good practice?
I think that you have to have that multidisciplinary approach, because what I've learned in looking at our provider team at Bateman Horne Center is our rheumatologist brings obviously a wealth of information and a vantage point that others do not. But you also have to have somebody who understands, family medicine and obviously internal medicine, but family medicine. You need to be able to bring in allied health professionals like PT, OT, and speech, because once again, they're the people that help support the patient inside their body, outside of your clinic, right? And how to live with this illness. But you have to be so careful with those disciplines, because if they are not informed, then they can cause more harm. And yet they can also cause they can serve as the biggest support network for that patient if trained. I think that it's important to also have a lived experience advocate in your center. That's something that we focus heavily on as well. I would say, as far as the care goes, it's pretty difficult to create a center like Bateman Horne Center within the typical constraints of at least the way that American medicine practices with insurance, because you just don't get reimbursed, right? And so a lot of these clinics are having to go to a cash pay model to give the providers the time that they need. So I think that's another key element, is however these are structured, it allows that provider to practice how they need to practice with that patient. And sometimes that's a 90-minute visit, right? And other times it's not. For us, I think something that strengthens what we do is, Dr. Bateman's and Dr. Vernon's vision of putting research under that roof, because we learn so much through the clinical research that we do. It helps validate what we're doing clinically, and our clinical care helps inform what sort of clinical research we should be doing. So for me, I would say that those are the main key pieces. If you can provide some sort of arm that includes the ability to do some of that clinical research that feeds back into the whole cycle, you have a multidisciplinary trained lens and approach, but you also have to have an infrastructure that allows these providers to practice medicine how they need to.
Which sounds like a powerful argument in favour of our discussions around a national research hub and a national centre of clinical excellence. So you've made comment about patient advocates feeding into centres. Do you have experience of running a pool of patient advocates to feed into either medical schools or local centres? That's a question from Michael. Thank you.
A lot of the work that Solve ME and ME Action do have more of those specific pools of advocates. Not that Bateman Horne does not also, but our pool probably is a little bit more focused on this network that we've created with lived experience professionals. So a lot of the work and product that we put out is generated from, doctors who have the illness, or, PTs and OTs and speech therapists who have the illness, and they are our advocates, but on a professional level. So we're able to reach their disciplines in, I guess you could label that an advocacy, but education focused way.
Okay, thank you. I think I've covered most of the questions that I've picked up through the chat. I know I haven't covered absolutely everything. Let me just check. Yes, could you just briefly highlight the crash survival guide idea?
Oh yeah, that's another one of my favorites. The MECFS Crash Survival Guidebook was developed a few years ago with a team of lived experience experts around me. PT, OT, speech, internal med, women's health experts who have experience in living with the illness or caring for people with the illness. And we collectively kept going back to this need of what do you do when you're in a crash, right? Like it is so scary.
Mm-hmm.
As a caregiver, it's like the most debilitating moment is not knowing what to do, right? And seeing them, in that state is just painful. Living in that state as a patient is more horrifying, right? And so while we can't necessarily, you know, cure PEM right now, I hope one day we get to that point. We're hoping that this survival guide, if you will, not only helps equip providers and caregivers up front with supporting the patients so that it can allow for more pacing and keep them from going into a PEM an episode, but rather if you're there, what can you do to conserve energy and make sure that you don't get deeper?
Mm-hmm.
So
That sounds like
that,
an
yeah,
absolutely brilliant thing that we should be doing. I think you also make mention in relation to severe ME, the idea that medical practitioners should actually be proactive.
yes,
Because we find, I mean, I wouldn't say the numbers, but there are tens or hundreds of thousands of people who just kind of go off the primary care radar because they don't find any benefit in being in touch with their GPs, and to be in touch with your GP takes too much effort and persuasion and involves so much knockback. So yeah, so I think the idea of being proactive is really interesting, and it's probably not something we've pushed as much as we could do.
it's hard though, right? Because,
Yeah.
as a patient, you're sitting there like, shouldn't they know? Why do I have to teach them, right?
Mm.
And so it's a very frustrating and energy consuming part of living with this illness is having to be both your own advocate but also your own educator and trainer of your physician. And so that's why we're hoping that tools like the clinical care guide can serve as that voice for you, right? And focusing in on, I'm really struggling with my sleep. Let's focus on that. Then let's move to this in a way that helps even the provider compartmentalize and serve you as the patient better.
Mm-hmm. And there's a question from somebody in the US about if you are living and you are severely ill or very severely ill, and you're on your own, is there anywhere where you can find advocacy? Who could you turn to for support and help in managing appointments,
Yeah.
and setting up care, etc.?
Um, I I hope they're okay with me doing this, but Mass ME, they are one of my favorite groups here in the US because I find that they go above and beyond to help support patients and they really understand this. But also, we just created a state by state resource directory with the intention of
Oh,
being able to offer direct connections into supports within that state. One day I would love to be able to, expand that into something more global. So.
that's stunning. That's exactly what we would love to have is a region by region guide involving local groups and access to local support. That's just a fantastic bit of work. Brilliant. A couple of questions around avoiding further inflammatory immune dysregulating events and vaccinations. Are these helpful or are they insults to a system that's already struggling?
I won't offer patient-specific advice on the vaccine because it is very patient-specific, right? But I think that prevention, however that may look for you, is the most important thing because, as we all know, the more insult or work that our body has to do to fight something is, again, more energy that it's using, and of course, it can tip someone further into the illness and severity.
Okay. And so yes, support from the World ME Alliance about talking about creating a global directory of resources. There is already on the World ME Alliance a global medical education hub. So that's a place to go to for that resource. I think we're just at 4 o'clock. So it's been an absolutely incredibly both informative, but also I found it really uplifting that somebody can do this work and can pull together such an incredibly well-written, accessible, and clearly patient-focused guide. I cannot express enough our gratitude to you, both for producing the guide, but also being willing to come and talk to us today. My contact with Bateman Horne Center started about a year or so ago. Lucinda Bateman had offered to come and do a talk. I hope that at some point in the future she will come back, because we'd love to see her as well. But we've absolutely loved having you. This has been absolutely brilliant, and I'm so appreciative. And to everybody else here, if you think it's great for Ford ME to carry on doing talks like this, maybe every 4 months or something, we could probably do 3 or so a year. And they're available globally, so you don't have to be in the UK to watch them. But we'd be delighted to do that, I think, going forward. So that would be fantastic. So can I just say big hug, massive
thank you. Thank you so much for having me, and please don't be a stranger. The only way that we get ourselves more support and care is if we do it together. So
absolutely. So please read all the thank you messages in the chat.
Thank you.
And thank you to everybody here for coming to the AGM, for coming to the talk, and we hope to see you all again very soon.